Hi, this is Pat Iyer with Legal Nurse Podcast. I am bringing today to you Irene Nobles, who is the president of Allegiant Health Consulting. She is a legal nurse consultant with extensive experience in healthcare, started off her career as a psychiatric technician working with people who were chronically, mentally, and criminally insane. And she learned about violence against healthcare providers well before the conversation that we're having today about the safety of healthcare providers within the field. She gravitated to the area of clinical risk and compliance issues and provides attorneys with services related to evaluating long-term care cases, which is her passion. Irene, welcome to the show.
Thank you, Pat. It's an honor to be here.
I know for people who have not experienced the differences in various clinical backgrounds and clinical settings, could you share for our listener what are some of the specific challenges associated with taking care of people in a long-term care setting?
Sure. Well, taking care of that population is very different than addressing, typical acute care patients in a hospital setting. It's a geriatric population typically, and along with that, there are behavioral issues that sometimes come as dementia sets in with some of the aged population. So there is a specific training that needs to happen when you're working in that area and that population, because the regulations for nursing home and long-term care is very different than what governs acute care and how we approach care delivery for those patients. So that kind of bleeds into an LNC reviewing a record for that type of care. The approach is going to be different, and you have to have a little bit of a knowledge base in order to get started with that.
I know that long-term care is probably one of the most heavily regulated portions of healthcare. First of all, why is it so heavily regulated?
Well, I think it's because the nature of the population that we're dealing with is very vulnerable. They tend to be at a higher risk for being subject and victims of abuse. And I think the regulations are put in place in an attempt to try to protect the residents from those circumstances of, exploitation, financial abuse, verbal or physical abuse, which unfortunately still is common in those settings today. So the regulations are put in place to ensure that there's at least a minimal baseline level of care delivery. And it sometimes isn't always practical. But it is there to, I think, to really protect the vulnerable population of the aged adults.
And could you give our listener a sense of which agencies are involved in regulating long-term care?
Sure. Primarily, it's going to be CMS, the Centers for, Medicare. Those are the federal regulations that govern all of those healthcare skilled nursing facilities across the nation. And then each individual state has their own set of state guidelines and regulations that supplement the federal regs. And typically, each nursing home is required to put processes in place and follow both sets of regulations. And when it comes down to determining compliance and whether or not the facility is meeting the requirements, they're going to go with the strictest set of rules when identifying deficiencies. And so even though you may be following state regulations, if you're not following the federal regulations, you can still be cited as deficient, in that practice.
When those surveyors come in, I know that there is a big focus on looking at the medical record. They sometimes can be brought in because of a complaint, and then they are evaluating a specific chart or a series of charts. And they can also do medical record review during routine surveys. I know that it's a surprise to people who are used to looking at hospital charts when they see a nursing home chart and notice the differences. What are some of those differences?
Yes, it's definitely very, very different, Pat. And I've reviewed records for both. But one of the main challenges to consider is not all nursing home facilities are fully electronic, for starters. Their records are typically still going to be partially electronic and partially on paper. And with that being said, it is considered or can be considered a long-term care environment for nursing home. Initially, some residents will go there for rehab, and sometimes the expectation is to transition back home when their therapies have completed and they've made progress, but that's not always the case. And so sometimes residents make skilled nursing homes their home. And so they can be there for a very extended period of time, and that could be months on end and even years. So that results in a very voluminous medical record. And part of the process is to also thin those paper records. And as they get thicker and consume, become voluminous, those records are then taken and stored in medical records. And so care delivery can sometimes be a little challenging because you don't have access to some of the previous records, particularly if there was a diagnostic exam or something that happened a year prior. It may not be in the current record right there on the chart, where nurses won't have access to it. And so that causes a lot of breakdown in continuity. But I think there's different chart sections as well, which is another key component. And if you're not familiar with the different chart sections and the type of documents that you would find in the record, you're going to have a more difficult time or more challenging time trying to analyze the facts of the case.
I know that one of the things that surprises legal nurse consultants is that they start looking for nursing notes that are being written 2 times or 3 times a day, frequent physician visits, treatments that are all on one piece of paper as opposed to scattered in shifts. Can you talk us through what we could expect to find in the way of nursing documentation and then physician documentation?
Sure. Yeah, there's definitely a difference in frequency of documentation. The expectation is not going to be as often in a nursing home setting than what's required in a hospital. You're going to most often see nowadays with the electronic record, most of the nursing documentation should be in electronic format, and you're going to see, your standard admission assessment. They're required to do skin evaluation, so you would see a Braden score and a skin check. There's going to be other types of documents that are surrounding various assessments, like an elopement assessment and a side rail assessment, a smoking assessment, all of those different things that you wouldn't necessarily see. And then the physicians typically are the people that make up the paper part of the record, because most of the EMRs in nursing home they have no integration. They're not connected with any other EMR in the healthcare system with the providers that are coming to see those residents. So the records don't interface. And so facilities do not force or mandate the physicians to gain access to the existing electronic record and do their documentation in there while they're visiting the resident. And I'm not really sure why that is, because I know when physicians go to the hospital, they are required to log into the EMR and document their notes, whether it's through drag-in dictation or typing it directly in the system. Orders are required to be electronic, but for some reason that doesn't carry over into nursing home settings. And so when they get there, they're writing paper orders and paper notes and those sorts of things. And that has to go somewhere. So this is why they create a paper chart. You're going to see other various consents in the paper record. You would see labs and diagnostics. Again, those are not electronic. Baseline care plan and MDS, which is called the minimum data set. We'll get into that a little later, but that's a major assessment that the interdisciplinary team puts in place. And even certain flow sheets from nursing you would see in paper format, like neuro checks, for example, things of that nature that are incidental, that come up as things arise. Usually those are in paper format. And so you can imagine if there are orders and doctor's notes and labs and diagnostics in a paper chart at the nurse's station while the nurse is out on the floor with her med cart and her computer assessing her patient, she's not necessarily going to have convenient access to perhaps some important information that she would need at the time when she's at her fingertips. So it's a back and forth situation all the time of trying to run and gather information and then back out onto the floor to treat your patient. So it creates a challenging dynamic when caring for patients in that setting.
I had not considered the hybrid aspect of the chart as causing that inconvenience. I was reviewing a chart just about a month ago that included some handwritten physician documentation. And having grown up in the totally handwritten medical record and then transitioned to an electronic one, it was like a rude shock to go from the electronic part to, oh, that's right, I have to decipher physician handwriting again. I haven't had to do that for quite a long time.
Right. Right. That still exists. That, like I said, most of the time they're doing hand notes. Now there are some consultants that will come in and bring their laptop and type notes and dictate notes into their own electronic system, and then later they'll fax those electronic notes to the facility. But again, it's the lack of EMR integration that an interface that creates that barrier, and not holding the providers accountable and mandating that they get into the system and document in the system itself when they're there at the facility.
Yeah, that sounds like a cumbersome system to me, Irene.
It is.
I could see easily a physician forget to do it or get distracted, or it might not be timely.
Correct. So they may come and visit and do rounds on all their residents and see 20 people at one time, and then they're off, and so you don't necessarily know the outcome of that visit right then and there. We try to catch them before they run out the door, but we may be in another resident room and not notice that they left, or we wanted to ask them a question while they were here to go tell them something about their resident, and they're already out the door. And then you don't have any information because they go back to their office and might dictate notes or write notes and then fax that in later. So there is definitely a delay in the transfer of communication, between the nursing and the providers that come in and treat the residents.
And how often are physicians required to come in?
Per the regulations, they're only required once every 30 days. Believe it or not, when they're a long-term resident. Now, that is often not the case. They will often come more frequently. Some physicians will visit the facility daily, but they may not see the same residents daily. They'll come and visit maybe 2 or 3 at a time, then they'll come back the next day, visit another handful, and so on and so forth. So they are definitely more frequently present in the facility, but that doesn't necessarily mean they're seeing those residents all that time that they're there, if that makes sense. They're seeing a few at a time, so they may have been there every day but only touched base with that resident once in the previous 2 weeks, for example. So, and that's another thing that is different than the hospital setting, where the expectation is the physicians are visiting their patients daily.
Yes, as well as the use of hospitalists who are in charge of those patients in the hospital and don't have a private practice and are there much more frequently as well.
Right, right.
And then we get to nursing documentation, which is different again in terms of the frequency. Tell us about the expected minimum amount of nursing documentation.
Well, again, you know, there's always the nursing assessment on admission is the expectation. And if a resident is on Medicare, and so they are required, and they're there for therapies or skilled nursing as opposed to long-term care. So there's a difference between that. I know sometimes we use the words interchangeably, but typically when a resident is first admitted to a nursing home, they're there for a skilled need. They have a wound, they need IV therapy, they need physical therapy. Per Medicare, that's considered a skilled need. And so they're there for a certain amount of the days that Medicare will cover for that type of treatment. And then once those days are exhausted, the resident is either discharged or they're given the option to privately pay for a long-term care stay. And so if that happens, then the documentation requirements and the frequency changes. But while they're skilled, their nursing does need to have daily notes. And so there's usually a recap of nursing care that was provided for the specific reasons why the resident is there. So it's not okay to just put a generic note that says resident is fine, no changes, and document your physical assessment, because they're not there for that. They were there for an infection or a wound or therapy. And so nursing is required to specifically make notes on why the skilled nurse is necessary to treat that wound or what the patient's response is to the therapy interventions and things like that. So the detail needs to be a little bit more focused on the goals of the skilled nursing rehab stay. So, and then there's skin assessments and Braden scale, and that is required to be completed upon admission and then weekly thereafter. Which differs than acute care as well. Some institutions require daily Braden assessments and skin checks, or at least every shift in a hospital setting, whereas in skilled nursing, even though nurses may look at a resident's skin every day, they're not required to complete a formal skin evaluation or skin assessment, except once a week. So things like that. Documentation beyond that is really just that. There's not a whole lot that nursing is required to do besides, you know, those specific assessments. Then there's, of course, the care plan, which is supposed to be initiated on admission, typically by the nurse. It's called a baseline care plan. And then follow up, a reassessment of the care plan and revision of the care plan needs to occur on a regular basis as well whenever there's a change in the condition of the resident. There's no specific timeline for that. It's usually when there's a change, but along with care plan revisions comes the MDS assessment, which stands for minimum data set, and that is a comprehensive assessment dictated by Medicare that must be completed on admission. And that triggers the whole development of the finalized care plan. And so there is frequency requirements of how often that MDS needs to be updated and completed if the resident has a continued stay. So it's very different. It's very different than a hospital.
When you point out the MDS, it makes me think about a case that I worked on several years ago, in which the attorney had strong suspicion that the nursing home staff rewrote the medical record, and the issue at hand was a pressure sore that developed. And he found these beautifully written MDSs that were all in the same handwriting, and they were all dated for January 1st, a day he knew that the MDS committee was not meeting. And it was perfectly consistent detailed handwriting, and all of it, he established later, was rewritten at one time to try to protect the interests of the facility as opposed to the interests of the resident who ended up with a very extensive pressure sore. Have you seen instances where you questioned the documentation validity in cases you've reviewed?
I have. There was one case that I reviewed a few months back. It wasn't too long ago. And it involved a fall of a resident. And it was interesting because the nurse's note that described the incident had discussed that, this time that the resident was found, and indicated that the CNA had just been in there 30 minutes prior and the resident was sleeping. And so basically a very vague note asserting that they did nothing wrong, but the resident just got up unassisted. But when I went back and looked at the CNA flow sheets and their documentation, they had documented 30 minutes prior that they were there with the resident, but they didn't document that the resident was sleeping. In fact, well, they did. They made a note saying resident asleep in their note. But when I went to the flow sheets, I saw at that specific time that they took vital signs and had toileted the resident and documented a BM. So I'm thinking to myself, well, we can't have both here. We can't be toileting and having a BM and taking vitals at 2 a.m. when your nurse is saying they were sleeping at that time. So which is it, And then later went on to see that 10 minutes after that flow sheet note of being toileted and vital signs, there was a pain assessment completed and the resident had expressed severe pain and was medicated. So I looked at the MAR and saw that they were medicated for pain. And yet all this was taking place, 30 minutes prior to the actual documented time that the alleged incident occurred. So it made me start to think, well, why are we giving pain medication? And why is the patient reporting to 10 on the pain scale if they were sleeping at that time? And so it just didn't make sense to me. So I was able to kind of pick apart and look at the timelines. I looked at the transfer record when the resident was sent out to the emergency room for an evaluation. That time that they were called and what was documented on the transfer form was 10 minutes prior to the time that the nurse documented the incident actually occurred. So again, lots of things were happening prior to when she actually alleged the incident occurred. So there was some of those inconsistencies you can pick up on, but you have to know where to look. And when you mention the MDS, sometimes people don't even understand the right way to interpret that as well. And when was the MDS completed versus when was it signed that it was completed? They get the dates wrong all the time. And that's because the MDS, you have 14 days to complete that assessment from the time the resident is admitted. And oftentimes, because the MDS drives the care plan development, you're not going to see the care plan coming until after that. And so many times I see nurses that don't have the nursing home experience reviewing cases and saying that this is an incomplete, they deviated from the standard of care, they didn't complete a care plan like they should have on admission. Well, there was a care plan. It was called a baseline care plan. You're not familiar with that document and you were looking purely off of the care plan that's in the chart in the MDS, and it wasn't complete because they weren't completed with their assessment yet. And that's the reason why. And so again, there's lots of little innuendos like that unless you have that knowledge ahead of time, you may not interpret their record appropriately.
There are also documents that contain information about the resident that never make their way into that residence chart. Can you give us a little sense of what other types of documents the attorney might be able to request that would shed light on a resident's care?
Yes, it's supplemental documentation that I look for all the time, that necessarily aren't part of the medical record. Aside from the policies and procedures and perhaps protocols, or some facilities have standing orders, those are obvious. And most LNCs know this. If they're evaluating a fall case, they might think to request the fall policy, fall prevention policy, to help them interpret whether the staff followed protocols to ensure the safety of the resident. But there are other things that you can look for and request that really can give you some good insight into the quality of care that the facility provides, and can really help either support plaintiff claims, or on the flip side, help defend against them if you're working for the defense. One of the most common things that I always try to look for is the CMS star rating report. It's called the Quality of Resident Care Reports, and star rating reports, which you can find on the CMS website. And basically, each nursing home is rated on a 5-star scale, much like a hotel, right? 5 stars is the great quality care, and 1 star is not so great at all. So consumers can go on and look at the star ratings for those facilities to get an insight into the quality of care. And there are certain quality indicators that the facilities are required to submit data on, and that also comes from deficiencies, state surveys, MDS, complaint investigations. All those things kind of comprise that data. But the star rating and quality reports, state survey inspection reports, which will highlight deficiencies that were identified, the corrective action plans that the facility had to put in place to correct those deficiencies. Those things can be accessible. I like to look at the daily staffing reports, hours per patient day, to make sure that the facility is meeting the minimal state requirements for staffing ratios, because you hear that a lot as being a claim that they were short staff. And that doesn't necessarily mean just because there weren't, lower nurse to patient ratios that they were short staffed. You have to prove that they were short staffed, and you do that by looking at their daily staffing ratios, and there's a formula they use, but you can look at those reports. I also look at other things like resident council minutes, meeting minutes. So all nursing homes are required to have a resident council where the residents can get together and talk about their concerns or suggestions for activities and different things like that. And they are allowed to invite a facility member to attend that meeting. And so a lot of times you'll get some good information from resident council meeting minutes, where they might be discussing call-out issues or linen issues, housekeeping. The food is, cold or not getting what we ordered, random things like that can help. I've gotten some good nuggets out of that, particularly when there was a fall case and there was accusations about timeliness of response to call lights, and there was huge delays, and this is why the resident got up and no one came. So then I might ask for the call light report. Because a lot of those call bell systems can run reports on the response time, specifically to that resident from their room. So you can look at that and see, oh gosh, yeah, they rang their bell and 45 minutes it was ringing and no one came to shut it off. So you can validate, some of those claims by looking at that supplemental documentation. A lot of times you can have access to the incident accident logs. You may not get the actual incident report, but you can look at the logs. That's the first thing the state surveyor asks for when they come in, is show me your incident accident logs. And facilities are required to keep a log of all those events in their facility. So if you're pulling that log and you're looking and you're seeing 25 falls in a month, we have a concern about safety in this facility. So those are very valuable pieces of information. Grievance logs, same type of thing. When a resident wants to file a grievance, social services is required to log that. and summarize what the grievance was. Infection control logs, wound care logs, all the logs are things that you have access to. And then I like to look into employee files sometimes because I want to validate that the employees have had and completed the required competencies and training for long-term care and what's required in those settings. So things like that are good supplemental documents to consider.
You brought up some things that I didn't know was available. And I think over the years, in particular, attorneys ask experts, is there any way of knowing how long that patient's call light was on? And in older systems, there is no way, but you're describing now that it's much more readily available to find that data.
Yes, yes.
Alone can make a huge difference in a case.
It does. And when I was the director of quality and risk management for an acute care rehab hospital, I was also the patient safety officer, and I was in charge of obviously collecting data on our core measures, and falls was one of them. And I also led the falls team and developed the fall policies and the fall prevention program. So the call light report was data that I looked at all the time. I later became the chief nursing officer, and I was also required to pull those call light reports because when we looked at patient satisfaction surveys, patients will make comments and they'll say, no one came, the call light was forever, those sorts of things. So I wanted to validate the truth behind that. And so I would pull those call light reports and look at that patient room specifically to see how long that call light had been on. And that was helpful then to go back and, re-educate the staff or change your processes, look at why is there a call light delay? It's not always staffing, there are other issues that you need to look at and consider. And so, but again, unless you have that exposure or know that that's available to you, you could potentially be missing some really great information that can help you with your case.
I know that the person who's watching this on our YouTube channel or listening to it on the audio channels is going to say, how can I reach Irene to ask her a question? What would be the best way for that to happen?
Well, Pat, individuals can email me. That's the best way. It's Irene at allegianthealthadvisors.com, and that's ALLEGIANT Health Advisors with an S.com. Or that can be found on LinkedIn. I do not have a website at this time. That's in the works right now, so I don't have a web address to share, but certainly I'm very responsive to email, and I am responsive on LinkedIn.
Well, Irene, I so appreciate you sharing your expertise. I know from this brief conversation that we had that there's so much more that we could have talked about, and in particularly my biggest takeaway from what you shared is the vast amount of information that's available beyond the resident's medical record. If the plaintiff attorney, for example, doesn't know to ask for that through the help of a legal nurse consultant, the facility is not going to volunteer that information, particularly in cases where it's not going to be helpful to their defense. So it requires us as legal nurse consultants to be aware of what's available and the nuances of nursing home care cases. Get a good person like Irene as an expert witness or as a background person to help you with a case. If you're handling a nursing home case and you're not familiar with it, it is its own world, and it's very different than acute care or outpatient care or long-term psychiatric care. Each little world has its own ecosystem, rules, documentation, regulations, and information that helps you, after the fact, establish what occurred in the care of a particular resident. So thank you so much, Irene, for being here with us. It's been wonderful.
Thank you, Pat. It's been my pleasure.
And if you have not already downloaded the Expert Edu app from the Apple Store or from Google Play, that app is a way for you to stay in tune with us, to watch the videos and read the articles and watch the podcasts that I produce through Legal Nurse Business. There are tips for you as a legal nurse consultant, and also if you are interested in writing and improving your writing skills. Another part of the app is designed to help you with writing. So go to the Apple Store for Apple, or Android is Google Play, and download Expert Edu, which is my app covering education for experts and supporting people who are interested in helping improve their skills, whether it's through legal nurse consulting or writing. Be sure to come back next week. New show, new guest, new topic. Thanks so much. Hi, I'm Pat Iyer. This is Legal Nurse Podcast. I am with Rick June, who is in Alberta. We've been talking about some of the components that help make your legal nurse consulting business successful. Rick, what were some of the key topics that we covered in your podcast?
Thank you, Pat. Some of what I thought were key points was, first of all, you need to be crystal clear about who you are and continue to remain aware of how you're growing as a person and reacting to things around you. That makes a big difference to the relationships that you're going to have with your clients and how they play out. The second thing is it's helpful to know who you want to serve. Who do you want to be your ideal client? If you have an idea of who you want as your client, you will find that those kinds of people resonate with you and are drawn to you. But you need to understand who they are first. And then the last point is you need to have a sense of what the pressures and triggers are that your clients are facing in their own work environment, so that you can provide a little bit of give and take. It's nice to know your boundaries, but it's also nice to understand the things that are causing them concern and some of the triggers they have that they feel very pressured to deal with. I would say that I guess those are the three most important things in my experience that are helpful to pay attention to as you both start your business and continue to grow it.
And Rick is a small business coach and consultant who is also an entrepreneur who has established several successful businesses. Be sure to catch his podcast, Rick June, and I'm Pat Iyer, Legal Nurse Podcast. We would love for you to watch his show and get some of the tips that we shared in his show specific to what makes a legal nurse consultant successful. See you there. Thanks.
Thank you.